Good morning. I am Dr. Yasodha Natkunam from Stanford University School of Medicine. My topic today is on extranodal NK T-cell lymphoma. I'm very happy to connect to make this presentation. However, I'm quite sorry that I couldn't travel to Cusco to actually be with you in person. Okay, so to move on to the lecture, extranodal lymphoma of NK or cytotoxic T lineage presents with vascular destruction and damage, prominent necrosis, and an association with EBV. It is highly prevalent in certain geographic regions of the world, such as East Asia and Central and South America, where these lymphomas account for 15 to 20% of lymphomas. However, these are quite rare in the West, where it is less than 1% and very rarely seen in those geographical areas. This lymphoma most commonly affects adults between ages 35 and 58 with a male predominance. It is also known to be associated with certain haplotypes that are higher in the populations where this lymphoma is more prevalent, and those are shown here. In the new WHO 5th edition classification, there are two clinical subtypes which are now very nicely defined. And these are based on the primary tumor location, but not the clinical presentation, although this follows from the sites of presentation. So the first one is nasal type. Up to 80% of cases are of this subtype. The other one is called non-nasal, so it's different than the nasal subtype. These are connected, and I will tell you why. So initially, this lymphoma involves the nasal cavity and the nasopharynx, oropharynx in the head and neck areas, like the epiglottis, Waldeyr's ring, epiglottic fold. The presentation site for the non-nasal subtype is only involved in the nasal cavity in very late stages, skin, GI tract, testes, and not the nasopharynx in the initial presentation. In the nasal subtype, the nasal cavity lesions can invade into the face or nasal floor or perforate the hard palate. And this actually is why the older name lethal midline granuloma was applied to this disease before it was discovered that it was actually a malignant lymphoma. Regional lymph nodes can be involved, and in late stages, there is systemic spread of this lymphoma to other sites. When you are considering a diagnosis of non-nasal subtype of extranodal NK T-cell lymphoma, it's actually very important to do investigations to rule out other sites of disease. If nasal involvement is found, it should actually be classified as a nasal subtype. And this has clinical meaning. So clinically, this lymphoma, as you know now, involves the nasal cavity and the nasopharyngeal regions most frequently. It can present with nasal blockage with discharge or bleeding. It can involve paranasal sinuses and leads to infection. There can be orbital involvement or perforation of the hard palate, and the patient can present with difficulty in swallowing or speech. Advanced stages, in advanced stages, the symptoms are usually related to organ involvement. And also systemic B symptoms are quite common, and bone marrow involvement, often with hemophagocytic lymphohistiocytosis and pancytopenia, can also occur in this disease quite often. So these are, again, other manifestations of the disease if people present with the disseminated form. In non-nasal extranodal NK T-cell lymphomas, it is clinically similar in that this can disseminate, but usually it doesn't begin in the nasal cavity. CNS involvement, central nervous system involvement, is rare and usually only occurs in advanced stage disease. So let's take a look at the morphology. Usually there is a diffuse, dense infiltrate with a broad cytologic spectrum. So it can be small cells, medium-sized cells, large cells, but it is the most prominent features are vascular damage. So it surrounds vessels and destroys vessels. And usually the blood vessels can also have fibrinoid necrosis. The necrosis and ulceration can be so prominent that it can mask the tumor cells. So whenever in this site you see a small biopsy with necrosis and there are no live tumor cells, it's actually very important to tell the ENT surgeon to go back to get more cells or more tissue so that this can be diagnosed. So this can be a problematic tumor to diagnose, and sometimes multiple biopsies of nasal cavity or oropharyngeal masses are necessary to make the diagnosis to see enough non-necrotic tissue to do the rest of the workup. The overlying epithelium can have pseudoepitheliomatous hyperplasia such as this, and that can lead to a problem with overlap of squamous cell carcinoma, and these can be misdiagnosed as a squamous cell carcinoma because of that epithelial hyperplasia. When we look at the immunophenotype, extranodal NK T-cell lymphomas, as you can judge from the name, can be of NK or T lineage. Up to 40% of cases can be T lineage marker expression, and that can be surface 3 positive, CD56, T-cell receptor proteins can be expressed, and T-cell rearrangements can be found. In addition, cytotoxic T-cell markers can be positive. They are often CD50 and can be CD56 negative in the T-cell version. It is not necessary to separate the T or the NK cell lineage for routine diagnosis because there is no prognostic relevance. Both of these lymphomas, whether they are T or NK lineage, when they have this nasopharyngeal presentation, nasal nasopharyngeal presentation very often can actually have the same survival rates and are aggressive lymphomas. Up to 20% of the cases actually can be CD56 negative. So this is another area that caution needs to be applied, because if you have a tumor that otherwise fits, it's EBV positive, but is lacking or is only partially 56 positive, that is still extranodal NK T-cell lymphoma. I've also given you a list of T-cell rearrangements in the NK lymphoma that is very typical. These usually will lack 5 in the majority, but as I have already told you, the T-cell subtypes may actually have CD5 expression as well. So the typical extranodal NK T-cell lymphoma of the NK phenotype actually lacks 5, but it can be positive for all of these negative for all of these markers. It is 50% of the time it can show CD30. So again, when you have a necrotic mass with CD30 positive cells, that can be a diagnostic dilemma. It can also be rarely positive for CD20 and mimic a large B-cell lymphoma, except there is EBV, so EBV positive large B-cell lymphomas will also be in the diagnosis in that case, but the location as well as other immunophenotypic markers like T-cell expression or 56 should raise the differential diagnosis and then get you to the right diagnosis. EBA is positive in the majority of the tumor cells in all cases, and that is definitional for this lymphoma, as well as several of these markers and transcription factors that are also positive, because these factors are involved in the pathways that regulate apoptosis and necrosis. So in the WHO classification, the essential criteria for this diagnosis are infiltration of the extranodal tissue by lymphoma cells with a variable morphology. They can have an NK or cytotoxic phenotype, and the majority of the cells are positive for EBER. It's desirable when you have angiocytic growth and necrosis, but even if you don't see it in small biopsies and you have the other 3 features, you can make the diagnosis. And for EBA detection, for EBV detection, EBA is preferred over LMP1 or other markers because those may be negative, but EBA is always positive in this lymphoma. There is, of course, a very strong relationship with EBV infection, which usually presents as a clonal episomal form in the tumor cells. The tumor also has type 2 latency patterns, which means that other genes of EBV are also expressed, such as EBNA1, LMP1, and LMP2A, but EBNA2 is usually negative. This is also not necessary to do when you do routine diagnosis, but it is good to know because it can be helpful to eliminate differential diagnostic considerations, especially when you see an extranodal NK cell lymphoma in an immunosuppression setting, as in a post-transplant patient or in an HIV patient or somebody who has been treated previously with chemotherapy or may have other immune conditions. In those patients, the latency type may be different and can be helpful in making the diagnosis. There are also other lifestyle and environmental exposures that have been described with this lymphoma. In the last few years, much of the genomic complexity of this lymphoma has been identified. I have summarized a lot of data here, but I wanted to just highlight the ones in blue that are of importance to know about. The deletion 6q21, it involves the tumor suppressor gene. PRDM1 is very frequently inactivated. Also, the JAK-STAT pathway and deregulation of NF-kappa B and PDGFR pathways are well known. Upregulation of PD-L1 as well as other genes have also been repeatedly found in many recent studies, and epigenetic alterations are another very important pathway for these lymphomas. In PD-L1, the checkpoint antagonists have also been used in the treatment, and I will present that a little later. The last but not least is the deregulation of microRNAs, and several microRNAs have also been described in the pathogenesis extranodal NKT cell lymphoma. Based on these pathways and subtypes, there are molecular groups that have been defined. I'm not going to go into the detail except to pull out this nice figure from this paper in Cancer Cell that goes into the pathway and the genes that are involved in the pathogenesis of this lymphoma. With treatment and prognosis, typically, these patients do not respond to anthracycline-based treatments like diffuse large B-cell lymphoma does. So chemoradiotherapy with a non-anthracycline-based regimen is necessary. The 5-year overall survival for early stage disease can be greater than 70%, and typically L-asparaginase regimens are used to treat this disease, and the overall response stage can be up to 80%. So there have been a lot of improvements in the treatment and prognosis of these patients, which a couple of decades ago were uniformly fatal, but now there are drugs that are actually much more effective, especially in earlier stage disease. The unfavorable factors in patients when they are treated with these more successful non-anthracycline regimens include advanced age, advanced stage, distant nodal involvement, a non-nasal subtype, and high plasma EBV content. And this is sometimes known as the pink index. Now, dynamic tumor load measurements are also done to monitor patients on treatment, and plasma EBV DNA level and a metabolic phenotype with PET-CT is often used to monitor progress. If there is continued positivity by these measures after the initial chemotherapy, the outcome tends to be inferior. This, and as I have already told you, this lymphoma is aggressive and it can very rapidly progress and disseminate. Immune checkpoint inhibition has been used because these tumors upregulate PD-L1. So in relapse recurrent extranodal NKT cell lymphomas, PD-L1 treatment has been used. Unfortunately, there has been a very uneven response. So not all patients respond to this. And it has b' suggested, however, that a combination of PD-L1, FOXP3, and CD68 expression, or 3' PD-L1 rearrangement specific target by FISH analysis may predict response. This is, however, not currently done for clinical diagnosis, but may become important as we learn more about this and there are more validation studies targeting this. Okay, let us now look at some cases. This is a typical case of an extranodal NK T-cell lymphoma. It occurs in a 71-year-old Vietnamese man with an ulcerated nasopharyngeal mass. Again, here you can see the pseudoepitheliomatous hyperplasia overlying this rather polymorphous looking infiltrate. It is uniformly and diffusely CD56 positive, and almost every cell here is positive for EBV. You can appreciate the cells and the pleomorphism here of this lymphoma. It is also associated with necrosis, as you can see in these pictures. This is another case of a 57-year-old Caucasian woman who presents with a history of recurrent sinusitis. So this is somebody who doesn't have an ethnic or geographic predilection from the disease, but the sinus demonstrated complete opacification with perinasal sinus involvement, and also there is a component of bony erosion. So the ethmoid sinus contents were removed with the differential clinically of infection versus neoplasia. So on tissue, we see these angiocentric angiodestructive lesions. The cells here are not as pleomorphic as in the last case that I showed you, but very nicely express CD3 and CD2. They were negative for CD5 and also B-cell marker. So you can see that it's got a very typical immunophenotype of an NK cell, and 4-8 are only a subset, 30 is a subset, but TIA, which is a cytotoxic granule-associated protein, is beautifully positive. CD56 was less than ideal. Only a few cells were positive and the majority of the cells were negative. It has a very high proliferation rate, and you can see from these two panels that EBV is highly positive, and also highlights here one of the angiocentric lesions going around a vessel. So we made the diagnosis of extranodal NK T-cell lymphoma in this case. And the point of this case really is to show that CD56 can be variably positive and even negative in rare cases, and this does not exclude the diagnosis. The presence of EBV and the cytotoxic granule-associated proteins in this case was very useful to establish the diagnosis. So to move on to case 3, this is a 44-year-old, also Caucasian woman who was previously treated for extranodal NK T-cell lymphoma and now presents with chronic sinusitis again, and fragments of tissue were removed. And again, you see a very necrotic and inflammatory process. This tissue was much more difficult. Even though it had CD56, it actually lacked EBV. So in this situation, it was actually questionable whether this was recurrent extranodal NK T-cell lymphoma, and we were not able to make a full diagnosis and requested more tissue for further workup. There were small friable fragments of tissue, extensive necrosis, obliterating architecture. There was granulomas, an infectious process was suspected, and it could still be, even though we couldn't detect other infectious organisms. The EBV may be lacking due to necrosis and ulceration. So this is why an additional biopsy, if there was intact and viable tissue, could be helpful, because we would repeat the EBER to see whether there were any positive cells. Additional immunohistochemistry and molecular studies were unhelpful in this case. So the overlap here is also in a patient who has had polychemotherapy, and polychemotherapy can also induce lymphomas that in the immunosuppression setting. So we could not separate this and asked for more tissue in this case. So this is another case of a 20-year-old Hispanic man who presented with severe abdominal pain, and a small bowel perforation was detected and the jejunum was resected. And here is what the case looks like. Again, a very atypical proliferation. It's transmural here and full thickness, and then shows somewhat of a mixed infiltrate, which was very nicely 56 and EBA positive. As you can see, the EBA is not very well stained, but there is enough positivity to make this diagnosis. And the differential diagnosis in this case are other lymphomas that occur in the GI tract, like enteropathy-associated T-cell lymphoma, which is associated with celiac disease, monomorphic epitheliotropic intestinal T-cell lymphoma, and other indolent T-cell proliferations. But all of these would lack EBV, so having that EBV was very important to make the correct diagnosis. In the WHO, as well as their ICC classifications, a new subtype of NK T-cell lymphomas have now been described. Unlike the extranodal lymphoma, this actually presents primarily in the node. Most of these lymphomas have a T-cell immunophenotype, but they can also be of NK cell phenotype. This is rare. This is a rare lymphoma, much rarer, in fact, than the extranodal NK T-cell lymphoma that I have been talking about. And it is most common in older adults and predominantly described so far in East Asian populations. It has a lymph node presentation and should not involve the nasal cavity. It, in fact, in these small studies that have been performed so far, has a worse outcome than extranodal NK T-cell lymphoma. There is diffuse effacement by medium to large cells. There is no prominent necrosis that is usually found or angiocentricity, so there are some differences for the pathologist to pick up on. It has a centroblastic cytologic features and looks more like a diffuse large B-cell lymphoma than an extranodal NK cell lymphoma. It can, of course, have also pleomorphism, in which case it looks a little bit more like diffuse large B-cell lymphoma. And EBA should be present in a majority of the cases, and up to 80% of the cases here are of T lineage, only a minority are of NK lineage, but can mimic extranodal NK T-cell lymphoma, so need to be very careful about excluding extranodal involvement, particularly in the nasal and nasopharyngeal regions. And this is what some of the pictures that are shown in the WHO 5th edition looks like, and you can see the uniform CD8 positivity, the cytotoxic granule-associated protein, and EBA positivity, and this is all occurring in the lymph node. There are also a very nice study that I wanted to highlight, which looked at nodal versus extranodal disease, and you can see the phenotype as well as where they present all outlined in the study, as shown here, and then also the worst prognosis that is associated with the nodal version. Neither one is very good, but this is even worse when you have a nodal presentation. Molecularly, there have also been nice studies that have shown similar alterations, TET2 as well as STAT3 pathway activation. So this actually overlaps with extranodal NK T-cell lymphoma, and it has a lower genomic instability compared to extranodal NK T-cell lymphomas or peripheral T-cell lymphomas, which have also been described in the nodal NK T-cell lymphomas. The diagnostic criteria for this lymphoma is very important. EBA may be present in the majority of the neoplastic cells, but the tumor should be primarily localized lymph nodes, and this is in contrast to the extranodal NK T-cell lymphoma. And in fact, in the definition, in the WHO classification, it actually spells out which of the other lymphomas you should eliminate, because this is a diagnosis of exclusion. Another NK lymphoma that is in the differential diagnosis of the extranodal NK T-cell lymphomas is aggressive NK cell leukemias. This is a highly malignant proliferation of NK cells. It's also frequently associated with EBV and has an acute clinical presentation, much like a leukemia. It is rare. It's most prevalent in Asian patients around 40 years of age. It can evolve from chronic active EBV or sometimes even LGL, large granular lymphocytic lymphoma leukemia presentations. So typically presents in the blood and bone marrow, but has high frequency of hepatosplenic involvement. But any organ may be involved and it can quickly disseminate. but circulating cells may sometimes be not easy to pick up because it may be very subtle. And it can be associated with marked cytopenia, so the patient may present with symptoms of anemia or thrombocytopenia as the initial presentation. Lymphadenopathy can be seen. Skin and nasal lesions are usually very uncommon. This aggressive leukemia can be often complicated by hemophagocytic lymphohistiocytosis, coagulopathy, and multi-organ failure, and they can rapidly deteriorate. Intravascular NK T-cell lymphomas, including this aggressive NK leukemia type situation, has also been described, but these are very rare cases, and molecular, genetic, and also pathogenetic information is lacking for better classification of those type of rare cases. And the survival in these patients is measured in months, so it's a highly aggressive and disseminated leukemic disease. And here are some pictures from a 32-year-old man with constitutional symptoms and massively enlarged spleen. As you can see, it really does present as sheets of NK cells with pleomorphism, and you can see here that they are involved by EBV. This same patient had massively enlarged spleen. Here again, you can see that the white pulp and red pulp have been displaced, and there is this very pleomorphic population that is positive for 56 and EBER. With flow cytometry and immunohistochemistry, so it has many markers that overlap with extranodal and nodal NK T-cell lymphomas. However, the CD16 is positive by flow, which can be a very helpful marker. And also, cytologic features can be highly atypical. These usually lack T-cell receptor rearrangements, as well as the T-cell receptor protein expression by flow or immunohistochemistry, but are positive for Fas ligand, and this can be picked up by a serologic study. So the pathogenesis is that it is positive, but not always positive, highly positive, so 85 to 100% in different studies. And it also is defined by typical gene rearrangements, although, again, the TET2, JAK-STAT pathway and the MAP kinase pathway activation can overlap. Up to a third of cases have also got the P53 mutation. So this is, again, very nicely described, but they overlap. So molecular doesn't necessarily help you as much as the clinical presentation and knowing the details of the patient to make this diagnosis. And here is a comparison table. So usually extranodal NK T-cell lymphoma are in older adults, aerodigestive tract. Many sites can occur in later stages of disease, but not in earlier stages. Whereas in aggressive NK leukemias, these sites are much more common and it lacks nasal involvement. Disease localization is very important for the differential diagnosis. Also, you can look for CD16 expression and some genetic abnormalities that may be important in their separation, but not always possible and clinically not always performed. The common features between the two are that they can be NK-derived. They are certainly EBV positive, although some cases of aggressive NK leukemias can be negative, and they're frequent in Asian and often Hispanic populations. And also there is frequent association with hemophagocytic lymphohistiocytosis. So to conclude, EBV positive T and NK cell lymphoproliferative disorders form a spectrum. HLH can be caused by EBV by itself or by genetic mutations or infections and malignancies, including the set of lymphomas we talked about. Some patients resolve with treatment, but it may be fatal in others, and it accelerates the clinical progression when patients have extranodal NK T-cell lymphoma. So these patients need to be followed very carefully so that if they develop HLH, you can catch it in the bone marrow and take necessary treatment steps to control the disease. The patients with extranodal NK T cell lymphoma can present with nasal or non-nasal subtypes of disease. Chronic inflammation or other lymphoproliferative disorders, such as chronic active EBV, can present in Asian and Hispanic populations as a prodrome to developing these aggressive lymphoma. No such prodromal risk is known in Caucasian populations. And then the nodal T and NK cell lymphomas are now better defined. They show distinctive features and an aggressive clinical course, and in fact, a worse clinical outcome. Aggressive NK leukemias, which is also another malignancy that can overlap with extranodal NK T cell lymphomas, has a blood and bone marrow presentation and is often disseminated and is frequently, but not always, associated with EBV. Thank you very much for your attention.